is toric IPCL implantation by Dr. Gaurav Luthra. He is cataract and refractive surgeon and medical director of Drishti Eye Institute, Dehradun. His special interest is in the field of refractive surgery, challenging and pediatric cataract surgery and keratoconus. He is presently chairman of academics and past president of IIRSI and founder member of World College of Refractive Surgery. He has done over 200 live surgery demonstrations and 5 orations and 4 named national awards to his credit. And he'll be now operating in the left eye of this 22-year-old gentleman with high myopia and myopic astigmatism with a refraction of minus 10.75 diopters spherical and minus 1.5 diopters cylindrical at 160 degrees axis in the left eye. And his PCVA is 6.9 in the left eye. In view of high refractive error, and he's chosen for phakic IOL implantation, though his pentacam maps were pristine. Corneal thickness of 507 and 505 were noted, which were not amenable for corneal-based procedures. And he has adequate internal AC depth of 3.59 and 3.64 in right eye and left eye respectively. Over to Dr. Gaurav.
Thanks, Dr. Tulsi. So we are going to use the IPCL, the toric IPCL. I've been using them for a few years and I'm very happy with the results. The vault and everything is nice, and they come in sizes which are very good because they come in steps of 0.2 instead of the 0.5 which is there with the other ICL that we use. So here I'm going to make my 2 incisions, and I don't know if you are getting the 3D effect or not, but I'll try to show you a 3D image.
It's coming just like the 2D.
Why not Ovarian in this case, Gaurav?
We are using Callisto. Can you see the Callisto overlay? Or you are not getting the Callisto overlay?
No, we're not getting image.
Guys, team, can we? They are not getting Callisto overlay.
Please increase the intensity of the Callisto.
So we are using Callisto here, and I'm getting a Callisto display on my microscope on the screen. I'm trying to get it for you. So I've just done the marking on the cornea from the Callisto itself. So what we can do is the external camera will show you the Callisto overlay from the screen in a moment. So
now it is visible. Yes.
Right. We are trying to show it from the screen directly.
Yeah.
Yeah, better. Nice.
But is the depth of focus perceptible there or not?
No. Actually, 3D is not working.
It's better to see without the glasses.
With the 3D on, your face is better. You look more handsome. That's it. Otherwise, it's...
Yeah.
So here, all my colleagues are nicely watching in 3D here. So,
But here on the screen, it's not visible. 3D effect is not there at all.
so now I've loaded the IPCL, and it's a toric IPCL. So I'm going to use counter pressure.
Gaurav, what is the size of the incision you made?
I've made a 2.8.
Okay, that's good. So do you find putting IPCL much better than the ICL?
So the handling is more like an IOL because
incision size and all. Yeah.
It's a very good lens, and because the handling is very much like an IOL, frankly. So that's a good thing about the IPCL that So I'm injecting, and with the IPCL, only thing is you have to be more careful that it can rotate while injecting. So you have to watch out for the landmarks, and if it's not going right, you might have to abort it sometimes. So now I'm just going to see whether my landmarks are coming out fine, and then only I'll proceed with the injection. So now I notice that they are fine because the orientation of those 2 small marks, it has to be superior. I'll be also showing you how we can check the vault on the OCT. We have an intraoperative OCT. So we'll show that once my ICL is positioned. Light mein dekho bete. Light mein dekho.
Even the leading haptic has a hole.
Yes. So there are several landmarks
on that
actually.
Hole also.
So these 2 holes have to be superior, and then the shape of the small holes which are there on the haptics and this small notch over here. These 3 landmarks tell you whether your ICL is opening in the correct size. So there are 3 ways to actually tell, and then this small hole over here, one is a pear-shaped one, and the other one. So you have to learn to see your landmarks well, because when you're injecting, they will all tell you whether you are opening up in the correct way. Cornea.
So you did very beautiful placement, looking at the position of the IOL
So now-
during the injection, because while you were injecting slowly, and then you could see that.
So
it's
the
going
good
in a-
thing is, sir, that the IPCL you can rotate while injecting. Two things. One is that you can change the direction even while injecting, which you can't do much with the star one.
That's right. That's
And
right.
second thing is that you can abort it. You can come out whenever you want. You don't
Yeah.
have to necessarily, continue. Even at the last moment, if you decide that it is not coming out correctly, you can just come out and it will come out.
That's
It won't stay inside. So now I've oriented the toricity. Can we have the overlay also, and then we'll have the OCT. Can we see the OCT, please? So
No,
while
no.
right now the chamber is only found with viscoelastic, but the OCT will show us the vault, and I'm going to try and show you the vault right now, and then later on. So now this is the OCT picture on the right side on your 3D screen, I think, and maybe you can see. I don't know if you can see the 3D. Can you see the OCT there on the right side, bottom?
The OC is not visible.
It's not visible yet.
No, it is there, I think.
No, it's not visible at all.
Okay. It will be visible on the.
What is the range of vault you want to keep?
So now I don't know. Can you see the OCT there? No.
No,
No,
actually
it's
the
not visible,
overlay is
Dr.
there, but
Luthra.
the picture is not clear.
On the 3D screen, can you see
Yeah,
on the
both-
right, bottom right,
both-
there's an OCT?
Both the pictures, we cannot see the images at all.
आप ना वो दिखाओ, वो वाला बॉक्स है ना, वो दो बॉक्सेस वो दिखाओ, वो दो बॉक्सेस दिखाओ. आप ये वाला मत दिखाओ, ये मत दिखाना, वो दिखाओ. So I don't know if you can see the OCT.
It is coming
Yeah,
very
it's
faint.
is coming, but
it's
very
not
faint.
clear.
Can
It's
you-
not
can
clear,
you make
it's
it better
faint
to see
actually.
the
It's
wall?
not well focused also.
कौन यहाँ वेट कर? नवीन आप करो. This is the cornea, so they have to go deeper actually, and then they have to kind of get the gain correctly.
Yeah.
So
Very faint.
I know I can see it, but they have to
Image.
just improve the gain. It is possible to do it. I think he's trying. Normally, the lens and everything becomes visible very nicely by man.
Yeah. This
So I'll proceed with my aspiration because I don't want to waste
Yeah.
time. We'll try to. Meanwhile, he's working on showing you the vault. Okay, नवीन आप try करो. कल आप कर रहे थे बहुत अच्छा. बेटे आप लाइट में देखो.
Gaurav, what is your targeted
will.
vault?
So I like to keep it between about 300 to 400 to 700. That's my usual target. So 250 to 750 is what they say is the correct vault. But up till, because with the center flow, even if it is a low vault or a little bit of a high vault, the tolerance is much better now. When we did not have center flow, it was a big problem. So normally I do hydroimplantation for my ICLs, but with IPCL I prefer to use viscoelastic because it becomes easier for me. But when I'm doing the star one, I tend to do hydroimplantation nowadays. So it's very important to get all the viscoelastic out. It's very, very important. Because
have you gone underneath the IOL or
no, I don't go underneath it because the size of this IPCL is such that you can easily aspirate under it even from the side. As you can see, I'm doing now. My aspiration is just at the edge of the optic, and I'm aspirating just under the ICL. I wish there was the 3D effect was good. You would have seen that I'm under the IPCL.
Right. And do you go with the aspiration at the central hole also?
Sorry, I used to do that, sir, but nowadays I don't actually do it. I used to go here and let the fluid run over here.
Yeah.
As you can see now, the bubble moved. So, but I've got most of the viscoelastic out now. So, but very important because you get IOP spikes because of viscoelastic, and even otherwise you can get TAS and other things. So,
Yes,
pilocarpine. So,
And that
but
too is-
sometimes if the pupil is very large in IPCL, I prefer to use some pilocarpine as well. Whereas normally I don't use pilocarpine, but in situations like this, it's better because otherwise you may sometimes get an optic capture if the vault is too high. So I prefer that when I leave it, the pupil should not be huge. Also, you will know whether there is any tuck. So most often I've stopped using pilocarpine nowadays, but in some cases like this one where the pupil is really big and the white to white is very big, so there I may decide to use OCT off kar lete hain.
Gaurav, in terms of rotation, because since this is a toric IPCL,
Yes.
in terms of rotation, how do you find the stability is better with this or the ICL?
So it's equivalent, sir. For me, actually, if the sizing is correct, it's almost equivalent, because it's only if you get an undersized ICL, very low vault, then the chances of rotation are there. And it's not common to get significant rotation actually. So, but I don't see a difference between the two products as far as that thing is concerned. But IPCL, the refractive results have been extremely good. I'm very happy, and the vault and all calculation and all is good. Using the white to white, the surprises are very rare. It's not common to get a surprise actually. So that's one good thing, and it's a relief, to have that.
Yeah, you get customized also with the IPCL, and especially.
And also
like,
now, sir, there are zero powered ICLs available. They've made zero powered IPCLs for practicing, for people who want to practice putting a zero powered IPCL in a cataract surgery in a pseudophakic patient. They've made some special new IPCLs which can be used by surgeons for this aspect. So.
And especially the wide range of sizes and vault with the IPCL, which we do not have with the ICL. With the ICL, we have a very fixed kind of sizes, 3 sizes or maximum 4 sizes, 3 sizes. But with IPCL, I think you can order the size and you get the customized size available for you. So in that terms, the power and all, you have a bigger range of power with this lens, I think.
So I think
what is the maximum power you have used IPCL, Dr. Gaurav?
IPCL, sir, actually I have only used a customized one up till about 23 or 24, but some people have, I think, used much higher than that. And I have done quite a few bioptics for patients with 30 diopters, where we put an ICL of around 20 and done about 7 or 8 diopters of correction on the cornea. But customized ones, I think, are available. I don't know the exact range. Maybe somebody else who uses IPCL will tell us.
Right.
Till what power is IPCL available?
And
minus 30, he says.
Right. And what is the minimum like you go in for the
Minus
IPCL when you consider from the refractive error point of view?
So I am now using ICLs and IPCLs for small parts like minus 3 and 4. Sometimes when a patient is not fit for refractive surgery because of a suspect cornea, or because of some reason because of which we can't do on the cornea, like there may be corneal issues. So I don't hesitate now to do ICL or IPCL even for smaller parts of 3 or 4 diopters, and we often do it. In fact, recently I've done a few hyperopes also, who are very high hyperopes, and luckily they had a good AC depth, which is very unusual. You don't get good AC depth with some patients. So as you can see now, I've just positioned the toricity correctly, and I'm going to close up, and if everybody is happy, then we can move on to the other OT where Dr. Arun Jain is already waiting
One
with his
question,
case.
Gaurav, one
Yeah,
question.
beautifully
One-
done surgery, Dr. Gaurav. Excellent.
Who's in the other OT?
And
Other
wonderful.
OT who's...
What is the incidence of doing PI in such cases?
Achha, Dr. Kumar is in
Do
the
you
other
do
OT.
PI?
So Dr. Kumar doctor is, I think, ready with his case. He's going to show us a very good Lucidis implant, which he is very fond of using. And I think in the audience also, Dr. Rajesh Tiwari and Dr. Harsh sir are using a lot of Lucidis implants. So we'll get
Dr.
to
Gaurav, Dr. Tiwari is here and myself is here. And
Great. So sir, please take over, and I'm transferring to the other OT. The
Yeah,
IPCL
yeah,
seems to be
yeah.
well centered now. And we can show the vault. Can we quickly show the vault in a moment in the OCT? That will give everybody an idea of how the thing looks. So if you can show us the vault. So if they're trying to show the vault, you'll have to go deeper. We don't want to see the cornea. We want to see the lens and the ICL. So, and you'll have to improve the gain. The gain has to be improved. Huh? Okay. So they're trying to get an OCT. It comes on the high magnification one. Low में नहीं आएगा वो vault. Okay, so now you can see it on the right side. Can you see the OCT screen and it's showing
yeah,
the
this is visible
better
now.
images we can
you
see
can
now.
see the iris, you can see the ICL, and you can see the lens. So on the right side, you'll see there's a bar which is about 1 millimeter, and that is equal to 1 millimeter there. So you can see here that this is just less than 1 millimeter, the vault right now. It should be around 800 microns on table. So the good thing is that if you have a poor vault, you can actually change the vault on the table, or you can see if there's an iris stuck, and you can even abort the surgery if you want, if the vault is very high. Sometimes you get, and if you have an inverted ICL or IPCL, you will know right here because the vault will be totally flat. So some people find it tough to operate because they won't know whether the IPCL is upside down, and I've seen some people make a mistake. So this can be useful on the OCT to guide you, and I think it's a great indication for using the OCT.
Gaurav, what would be your minimum accepted and maximum accepted vault after the surgery, like on the table?
So on the table, sir, see, I've started using the OCT only for a couple of weeks. This machine got installed only 2 weeks back. But so on the table, I'm only seeing this now, last 2 weeks. I've done only 4 or 5 ICLs in that time. But I would on the table, my tolerance would be that if I had a flat vault, I would immediately not proceed. I would explant the ICL because I would exchange it. And if it was about 1000 till 1000, I will leave it there because I know that gradually it will settle down a little bit. So maybe 100 microns to 1000, I would be happy. If it is less than 100 or 200 microns, and if there's a touch, I will abort it and go order a new ICL to be brought in. But that's how I would do, sir. So I think we can move on, sir. If we can go to Dr. Kumar's OT. Can we change the transmission to Dr. Kumar's OT, please?